Thank you so much, everyone. This is the September 28th, 2021 Provider Collaborative webinar. We're going to talk about coordinated care organization disenrollment requests and the prior authorization process. And today we have 3 different teams who are presenting. So I am representing the Community Partner Outreach Program. This is Jessica Diaz, but I also want to introduce folks at the Provider Clinical Support Unit and the Provider Services Unit. So I'm wondering if I can ask Brendan to introduce himself first.
Thank you, Jessica. Good morning, everybody. I'm Brendan McGee. I'm a registered nurse and manager of the Provider Clinical Support Unit. We process the prior authorizations that are submitted, and they are part of the continuity of care requests process as well. So thank you for being here. I'm anxious to share as much information as possible.
Thank you for being here as well. Arwen, can I ask you to introduce yourself?
Hi, good morning, everybody. My name is Arwen Wolf. I'm the Provider Services Unit Manager. I manage the call center that takes questions regarding claims and eligibility. And I will be happy to present the role of the Client Services Unit. They aren't here today, but I'm happy to talk about that and give as much information as possible. So welcome, everybody.
Thank you. I will start us off with a few training objectives and then hand it over to Brendan and Arwen. So today we are here to talk about how the continuity of care CCO disenrollment request process works, and also how to submit a prior authorization for an OHP member who has open card or fee-for-service eligibility, and what that process looks like and what to expect. We are going to start by setting the stage a little bit before we get to those primary objectives by giving a quick overview of how Medicaid or OHP is structured here in Oregon, talk a little bit about the difference between fee-for-service and CCO enrollment, and then towards the end, we are going to talk almost exclusively about the prior authorization or PA process. And so I will set the stage by saying the first half of this presentation is probably more widely applicable across our audience. If you are not directly involved with the prior authorization process, you may want to either listen in, or if you have other things you need to do, we recognize the second half of this presentation is more focused on that traditional provider who uses the provider portal and actively puts in things like prior authorizations. So setting the stage there, I think there's a lot of really great stuff that we're going to learn from Brendan and Arwen. And with that said, I'm going to skip us along to Brendan's first slide.
Thank you, Jessica. My slide is to first give you all an introduction and some insight into what the Provider Clinical Services Unit looks like. First item is an overview of the team members. Myself, the manager, as I said, I'm a registered nurse. We also have the Medicaid medical director as a de facto team member. Our medical director is an MD. She practices actively in the community and role within the team. She also is a medical expert for difficult determinations and helps with policy development. We also have a team of medical review coordinators who are also of clinical and education and expertise, and their primary responsibility is to help review the clinical documentation that is submitted with each prior authorization request and help determine if the request does meet criteria for approval based on the quality and quantity of that documentation that's submitted. We also have prior authorization review representatives who are technical reviewers who help set up, process, receive, set up, and forward the requests that require clinical review to the MRCs or RNs, and also have the autonomy to approve some prior authorization requests that don't require clinical review. They are actually our frontline team that has the most interface and interaction with our provider populations. Both the MRCs, the RNs, I'm sorry, I'm going to use those terms sort of interchangeably. The RN team and the PAR team both operate or maintain a hotline, a service hotline. The PAR group, who are the initial technical reviewers, they operate a PA hotline, which is intended to basically establish customer provider support in a way that allows you to check the status of a already submitted PA or ask basic PA submission questions. So support in understanding that process, how to initiate a PA would be routed through that PA hotline. We have a code pairing hotline that is operated by the RN's medical review coordinators that is much more in-depth related to code pairing issues as they pertain to whether or not a PA is required based on the specific nature and codes utilized in the request. So that is a much more in-depth and comprehensive look into specific PA requests. A side note on our team, we also have personal care program coordinator that manages the personal care assistance program, not related to prior authorizations. And we also have a clinical management utilization reviewer that assists with some of the mental health services, as well as an office support staff person. So in all, we have 18 people on the PCSU team. How we work together is actually the most important part of our work. We're comprised of, like I said, the technical and clinical reviewers who work in very close proximity to one another, not so much in a physical space anymore, much more remote work since the arrival of our COVID emergencies. But we also work hard to maintain a pretty robust level of collaboration and communication amongst each other. And we rely on each other and our collective wealth as subject matter experts to help work to ensure that our PA processes run as efficiently and effectively as possible to assist you as providers to provide the care that you need. We take a lot of pride in being able to process and turn around and issue determination on PAs as quickly as possible to make sure that there are no holdups on our end that would impact the timeliness or the quality of care that the providers are able to provide for your patients and members. And I've already spoken about the PA hotline and the code pairing hotline. Both of those hotlines are operated during what we would consider normal business hours, which for your all knowledge and peace of mind is between 8 a.m. and 5 p.m. Though there are times when agency meetings, team meetings take place where the code pairing and the PA hotlines are out of service. Those are all temporary things, and there is an automated voicemail that comes through that says that the line is out of service, and 99% of the time is because of a structured meeting. But for the most part, they are available from 8 to 5 p.m. Now I'm going to move towards a quick education on the next slide about Oregon Medicaid 101. In 2012, Oregon implemented the coordinated care model, which utilizes coordinated care organizations, also known as managed care organizations, to provide care for Medicaid recipients. A CCO is a network of all types of healthcare providers, physical health, addictions, mental health, dental, etc., who have agreed to work together in their local communities to serve people who receive healthcare coverage under the OHP, Oregon Health Plan, Medicaid. In October of 2019, OHA implemented what we call CCO 2.0 for coordinated care organizations. OHA signed contracts with 15 organizations to serve as CCOs for the Oregon Health Plan's nearly 1 million members. On January 1st of 2020, the 15 CCOs began service to OHP members across the state. And still to this day, we still have 15 CCOs in operation. The new contract sets new requirements for CCOs to improve care for OHP members and hold down costs to increase Oregon's Medicaid program. They're governed by a partnership among healthcare providers, community members, and stakeholders in the health systems, and have financial responsibility and risk. They also have one budget that grows at a fixed rate for mental, physical, and ultimately dental care. But they are primarily responsible and accountable for the health outcomes of the population that they serve within their network. Some of the CCO 2.0 priorities in that contract span over the next 4 years, the CCOs will focus on priority areas including improving the behavioral health system, increasing value and paying for performance, focusing on social determinants of health equity, and maintaining sustainable cost growth. The next slide is a brief, not brief, but a small, I should say, on my screen, a small map to give you a general idea of how the CCOs are laid out within the state of Oregon. Clearly, there's kind of a focus in more diverse CCO dispersal within the higher populated areas of Oregon, whereas Eastern Oregon is a CCO in and of itself. A lot more involved in the metropolitan areas, especially in the Willamette Valley. Next slide, CCO 2.0. This slide is basically just intended to give a quick visual that to show that most OHP members are enrolled in a CCO, but not all of them are. Upwards of 90% are enrolled in CCO. But we'll take a closer look at what that remaining 10% might look like who are in the open card or fee-for-service category. So for the fee-for-service or open card, when they are open card, a member, a Medicaid recipient, they do not have a CCO or coordinating their care. Their services are directly billed to OHA for their services, and new OHP members are on fee-for-service until CCO receives their information. That's part of the enrollment process that all are initiated in open card until a proper CCO can be assigned. Other specific populations may stay on fee-for-service or choose to opt into it. And CCO disenrollment for continuity of medical care is a topic that we'll actually cover here a little bit later in much more detail. And I know that's important to a lot of the providers who are here with us today, so thank you. There are some populations that are not eligible for CCO enrollment and must remain in a fee-for-service category. One of them is if someone has other major medical coverage, like employer insurance, OHP is billed secondary to that and other coverage, and is not, and they are therefore not coordinated by a CCO. They will stay fee-for-service. They may, however, be enrolled in a DCO for dental care if they're eligible. There's also the emergency care available for people who do not have a qualifying immigration status, we call it COWN, CWN. This is also billed fee-for-service. When someone is pregnant, their benefit package is increased to a COWN Plus coverage, which grants them full benefits for the duration of the pregnancy and 2 months after. This is also under the umbrella of a fee-for-service category. I will say as a side note, there have been exceptions in temporary rule based on the COVID emergencies that have extended some of the benefits under COWN specifically to make sure that care is provided in a very ethical and responsible way to these recipients. Next slide. There are some populations that also have special enrollment rights. For instance, the Heritage Native American members, they are automatically exempt from the CCO enrollment requirement, but may opt in or out of any level of coverage at their choosing. Child welfare or kids in the OYA system, they're managed by DHS staff, and they may exempt members from physical health coverage without needing OHA approval. There's also dual eligible members who have both Medicare and Medicaid, and they may opt out of physical health coverage without OHA approval. But OHA approval is required to opt out of dental and or behavioral health benefits with the CCO. Another category is those little ones in the medically fragile children program. They may be opted out of CCO enrollment per OHA discretion, and newly eligible pregnant women in their third trimester may choose to opt out of CCO enrollment and receive fee-for-service care. There are different ways in which someone can have their care coordinated, and this slide provides a breakdown of those enrollments. Most members have full CCO enrollment, but there is a dynamic between the different enrollment classes, between CCOA being full CCO enrollment, CCOB includes physical and behavioral health only, CCOE is behavioral health only, CCOG is dental and behavioral health only, and DCO is dental health only. There is no option for only physical and dental health. All CCO enrollment options include behavioral health. So this is a very important slide, especially if fee-for-service requests are going to be part of your life. If disenrollment requests, continuity of care requests, these are all interchangeable terms sometimes that we use. But this is an important slide, I think, for all to retain, consider, and reference. Just understanding the different categories of enrollment is very important. Next slide is disenrollment from CCO for medical reasons. In addition to the situations that I've already talked about, there's a process for by which a CCO member may disenroll from their CCO temporarily. CCOs have care coordination and member services team who can often help members to get their needs met without having to go to the lengths of disenrollment. Many times members don't understand what services are even available to them within a CCO and feel, because they don't know, that those services are not available when really they just need the support and awareness provided to them. Often education or assistance, getting connected to the right resources within their existing CCO can help resolve a lot of problems. I dare say most problems. Our client services unit, of which Arwin is the manager, and you'll hear from here shortly, and the provider clinical support unit, of which I manage, we really try to help members stay enrolled with their CCOs by helping resolve access to care issues or simple communication issues within their network. They just, a lot of times there's just a lack of awareness of what resources are available, and we have to connect those dots as much as possible to ensure, or at least promote, that continuity of care within the CCO until it is determined otherwise that maybe a fee-for-service disenrollment is appropriate. When they can't get their medical needs met through their CCO, it's imperative that they work with their provider to submit what is called a continuity of care or fee-for-service request, also known as an open card request. This is the last resort solution for this issue of care continuity. OHA reviews the request through, like I said, the PCSU, my team, and we may contact the CCOs for additional information that we could use to approve or deny the request. Like I said, many requests for these disenrollments can be resolved through effective care coordination and or member education. And this is the next slide is a graphic continuity of care CCO enrollment. And if you cannot read it now because of the size on your screen, I encourage you to please reference this presentation at a later date when expand it, where you can see it in detail. I know it's small print and there's a lot to be included in this, so it isn't very visually ideal, but there's a lot of great content in this disenrollment graphic. So we'll be talking about these steps in more detail over the next few slides to help better understand, but this is another kind of great quick reference to retain and utilize. And with that, I would like to pass the microphone over to Arwin Wolf.
Thank you, Brendan. So again, my name is Arwen Wolf. I'm the Provider Services Unit Manager. I'm here to talk a little bit about this CSU's role with the continuity of care requests. I'm not the manager of that unit, but I can definitely fill in, and Provider Services can help guide providers through the process if necessary. So this first slide, the continuity of care request, this is an important role for providers and community partners to help members connect with their CCOs and have conversations about their meeting their needs first. So the first step is if the member is in a CCO, members should contact their CCO first for helping resolve their needs. Members should document the conversation, including who they spoke to at the CCO. The CCOs are often able to resolve the member's needs. And if not, then if the CCO cannot help the member, then the member would call OHP for help, and that's client services. You see the phone number listed here for the continuity of care request. It's the 800-273-0557. It's really important to note that providers cannot call on behalf of a client, but can help them understand how the process works. The community partners can call on behalf of clients if they are present, but clients ultimately can call this number to request a temporary fee-for-service healthcare form, also known as an OHP 0416. Let's go over some of the work that the Client Services Unit does. Here are some of the ways that OHP members and community partners can work with CSU. So OHP and certified community partners can work directly with Client Services Unit to obtain CCO enrollments and answer questions about CCOs, handle requests to be on open card for continuity of medical care, provide general information about OHP medical, dental, and mental health benefits. They can also help educate members on how to access, use OHP benefits once benefits are active. It's important to note that CSU cannot make any eligibility changes to a member's case, such as address changes, or adding, removing household members. CSU will transfer the members or community partner to an eligibility worker who can assist with those needs. So the continuity of care request. The member must bring the form to their primary care provider for completion. So after they contact CSU, they get the form, and then they take it to the primary care provider for completion. The provider signs a letter of medical necessity, prepares medical records and other applicable documents, and submits the request with a form through the OHA's provider web portal. This is a copy of what the 0416 form looks like. This document is not publicly available and must be requested by a member from the Client Services Unit. We are sharing it today so that you recognize it when a patient brings it to you as a provider. This form is supplied by Client Services Unit to the member, who must then bring it to their provider. The Client Services Unit will often help the member to start filling it out, so it may be pre-populated with information by the time the provider sees it. So step 4 of this process would be the provider submits the form 0416 and any supporting documentation. Use the prior authorization function in the MMIS web portal and fax supporting documentation using the EDMS cover sheet, also known as MSC 3971. And with that, I'm going to hand it back over to Brendan.
Thank you, Arwen. I'd like to take a little half step back just a moment and just give a little emphasis, provide a little emphasis about the the temporary fee-for-service healthcare form. It was on slide 20, the form 0416. And just as the manager of the team that processes this form when these requests are submitted, I really just wanted to note and emphasize the importance of the quality of documentation that is provided with these requests and how much of an impact it has on the timeliness and efficiency at which these reviews can be made. The more in-depth and accurate and up-to-date information that we can receive in these requests through this form and the supporting documentation, the better we can do at processing the requests. So many times we see delays in the process that are a direct result of the absence or potential inadequacies of some of the documentation that is submitted to support the request for disenrollment. I just wanted to make a note of that and encourage, kind of be a cheerleader for providers to do the best that they can to provide us with adequate documentation to review and provide determination. With that, I'll go ahead and jump back over to slide 22. And this is a graphic. This is an example of what the EDMS cover sheet is. What I wanted to call attention to on this sheet, I want to discuss how the status of a fee-for-service disenrollment authorization request is to be entered. These requests are not considered urgent or emergent. Typically, definitely not emergent. These are something that is that takes time to process. So when submitting these, please mark routine on the EDMS cover sheet. If it is an urgent case, and I'm not speaking clinically urgent, because clinicians' definition of urgent and somebody in the business or operations side of urgency, those definitions, I'm sure you all agree, are slightly different. So if you have a clinically urgent issue, that's usually resolved within 3 days or so. In this case, we would consider an urgent request if services need to be rendered within and determination issued within a week or so. So if you truly do have an urgent request for disenrollment, for continuity of care request, please go ahead and mark the urgent or the routine, continue to mark the routine, but I want you to list in the justification line, and it's kind of highlighted here in this slide with the big bold red arrow. Please include details about the urgency in the justification field. And also, I would advise that a member of your team please call our PA hotline, and the number is listed there below in red, 800-336-6016, option 3. That will get you to the technical reviewers on the provider clinical support unit, and that will further inform us that we should be looking out for this urgent request and that it actually is urgent, and we will definitely expedite that review as best we can to help support your goal of providing services to the individual. Again, urgent if it would be a detriment to their care, their health, their safety, then it would qualify for that expedition. Thank you. Next slide. Continuity of care request step 5 and 6, excuse me. 30 days is a requirement for OHA to process these disenrollment requests. That is in rule. Any determinations that, or anything that is not determined within the 30 days is assumed to be approved. But we turn those around definitely within the 30-day requirement. We try to turn our prior authorization requests around in a calendar week. So if something is submitted complete, whole, and reviewable, you're likely to get a response within a very, very reasonable and positive time frame. A lot of that depends on, again, the quality of the submission in the presence of adequate supporting documentation. If we have to wait on more information, and that's either from the provider submitting the request or the CCO for their level of engagement, it can create delays in our process. But we do work very, very hard to minimize any delays at all to be able to provide adequate response. continuity of care requests, approved requests, CSU, which is the client services unit, and I'm sorry if I misspoke earlier and listed Arwen as the CSU manager. She's not. She's the provider support unit, and they do a great job over there. She's the manager over there. CSU will disenroll the member from the CCO within 1 to 2 weeks, sooner if urgent. Again, that could take up to the 30-day mark if the documentation or interactions are being delayed for whatever reason, and there are multiple reasons. But our goal is 1 to 2 weeks at the most, with full, complete, appropriate submissions. Denied requests, the member is encouraged to contact their CCO for care. They may appeal the decision by contacting client services and request a hearing. Members maintain hearing rights on denied authorization requests and denied services, denied claims. That is in rule. The continuity of care CCO disenrollment. This process is not how to change CCOs when moving. It's not open card for tribal members. It's not permanent. As disenrollment may be approved for up to 12 months or less based on the individual need and unique circumstances. So even those who are in very, very unique circumstances that likely may require or will require open card, fee-for-service, CCO disenrollment, that exemption for a lifetime will still require annual renewal of that status. And the process gets easier as time goes along, when expectations are known, and the clinical unit does their part to note circumstances, unique circumstances that could lead to prolonged or potentially indefinite disenrollment. Though again, I want to emphasize that it does require that annual renewal. If it's issued for a year. Any renewal actually is recommended that the providers be aware of that if possible, when possible, and initiate the request, assist in initiating the request of the member to continue their disenrollment in advance of the expiration date, because the system may, once that fee-for-service end date passes, the system, they may be enrolled in a CCO while they are getting their documentation together or preparing or in the process of submitting their request for their renewal. So we don't want that to happen, which is why we try to encourage members and providers as much as possible to be proactive and submit for renewal in advance of the term. And with that, I'm going to hand the microphone over to Jessica.
Thank you so much, Brendan and Arwen. There was a lot of really great information in that first half, or I guess a little more than half now, but the first part of this presentation. We want to open it up for questions and answers right now. So feel free to put any questions you may have in the question box. And we have a few populated already. So I am going to start reading them, and we can have, if we don't get to all of them, rest assured we are capturing them here, and we'll find a way to get that information to you, just in case suddenly there's a giant cascade of questions. But right now it looks like an amount we can probably handle right now. Let's see, so we have, I think it's more of a statement than a question, which is that because the form asks to specify who that CCO care coordinator is that the patient is talking to as that first sort of pre-step to disenrolling, has caused some confusion among CCOs and their care coordinators. I don't know if Brendan or Arwen, you work directly with those care coordinators at all or could speak to that.
The intent, thank you for that question. I'm sorry,
Go ahead.
Arwen. Okay.
No, go ahead.
Thank you, Ellen, for noting that. The intent is to promote a collaborative conversation between the member and their CCO as early in the process as possible to help address any deficits in their care or knowledge or awareness of the resources that are available to them at that time. Unfortunately, we don't have at our disposal the information pertaining to who the specific coordinators that they would need to speak to within their CCO. That's something that their CCO is obligated to be able to provide at the time of the service call. Can this happen after the client has taken the form to their provider? That is not the intent. Fair question, but the intent is that engagement happens first to ensure that the pathway towards disenrollment is appropriate, and that to ensure that their services that they require and want and are entitled to may be available to them within their network.
And I believe also a presentation similar to what we just gave was given recently to CCOs. I think is that how you got my attention for this one? So I think we are trying to also communicate amongst CCOs, similar messaging and that same graphic that you saw here today. Oh man, the crackles are back. I'm sorry, everyone. I do have, let's see here. I will read to the next one, which is, are substance use disorder, detox, or mental health considered urgent requests? And I think that can be a complicated.
That's a great question and a very, very complicated question, which I'm sure Christine knows very well when she asked it. Difficult to answer, and that would rely on consultation with our mental health clinical reviewer as part of the process. That person is not mentioned in any of the slides, but I guess in hindsight probably should have been. There is another person involved in the process when it involves disenrollment requests that would fall into the mental health or behavioral health category. And this person is a clinician and conducts the reviews that are clinically appropriate for those. And it's a really good question and difficult to ask or difficult to answer.
Yeah, I think maybe we
I
need
can see
to.
circumstances where something like that could be all the way up to an emergency.
Yeah.
And those are different altogether in terms of their requirement for coverage of benefits.
I'm thinking that I'd love to get some substance use disorder and mental health subject matter experts in to talk to us in a setting like this. So I'm going to add that onto my docket. It's a perennial need, and maybe we can finally dig into it again.
Yeah, thanks for that good question. That's a thought-provoking question.
I do want to tackle this next one. Actually, I want to do a plug for the Community Partner Outreach Program is doing next week a webinar module about CCO changes, which is a related topic that we do not have time to go into the detail we would need to today, but just know that there is a guide forthcoming and a presentation forthcoming about how to best help people change CCOs, which is also something that happens with the client services unit. So there is more content coming soon that's, I think, going to pair really nicely with what we just talked about today. And here's a question about how is the determination typically communicated to the provider and the member?
I can answer that question as well. Thank you, Maria, for I see a couple questions, and one of them kind of touched on the topic we just were addressing with the detoxing request. So in terms of notification of the determinations, the formal way is through letter. Letters are issued and sent upon determination to the members and to the providers who submitted the request. Having said that, I really, really want to also put in my plug for the utilization by the providers of the provider web portal for PA submission, because you can check on the status and outcome of PAs in almost real time. And you don't have to wait for a letter or be reliant on the mail carriers and a natural delay. So that's my plug. You will get an official letter from the agency, but please take advantage of the provider web portal. It's a great tool, not just for checking on the status of a PA, but for submitting a PA is much easier, more interactive with a team of reviewers, and it's the future. So please encourage everybody to jump on board with that and utilize it as much as possible.
Thank you. Let's see here. If a client wants to be treated with a specific agency, but that agency doesn't accept their CCO, can they use this disenrollment option?
So I can try to jump in here, and I'm not 100% sure on this. If the providers, and just correct me if I didn't get the question fully, but if the provider's not enrolled with the CCO, this isn't really meant to be used for that purpose. It's meant to be used if a provider isn't able to, how do I put it? That's a really good question. Can you repeat the question one more time, Jessica? Just make sure I got it.
Yeah, I think the crux of it is if someone wants to have a specific provider or organization treat them, but that does not fit in with their CCO network, are they able to
Oh,
disenroll for that reason?
yes, I would understand that this process would be used for that purpose.
And I think I would add the caveat of it may or may not be approved depending on if the CCO is able to meet the needs with a different provider. Like just having a specific provider is not necessarily going to be approved. Is that correct?
Yes, you are correct with that.
Yeah, I would like just to add to another nuance to that is that there has to be a unique circumstance, whether it's medical necessity, continuity of care, something unique that would qualify that provider as being essential for an optimal outcome for that member that could not be achieved through the CCO if they have relatively equivalent services available. So, and that would be demonstrated through the quality of documentation that is submitted with the request. So being able to illustrate why that request is essential is paramount.
And then let's see, there's a lot of great questions. I think maybe, and I see some about PAs starting to pop up, so maybe this is a good time to transition. But I think maybe if we can go over one more time, just making sure our providers understand like how to best communicate if something needs to happen on a faster or emergency timeline. I think it's important enough that it bears repeating. And if my question wasn't leading enough, I could start us too on what I think the answer is, which is how to.
I'm sorry, I was just having audio issues.
Oh, okay.
What was the question, if I may ask?
I think to reiterate how to best communicate if there's an urgent or emergency need. And I think it's a combination of using that cover sheet and adding in clear justification and then escalating to the hotline additionally if it really does need a human touch right away. Is that correct?
Yes, it is. Agreed. Absolutely. The two best options are to illustrate the urgency on the EDMS cover sheet and take another step to reach out to the PA hotline and inform the review staff that there is an urgency.
I see we have some really helpful staff who are listening in who have added some context like, so the letter that gets generated will also have a date of expiration, so the provider and member will know that they need to resubmit if necessary. I have to say I'm not an expert. Does that sound accurate?
Absolutely. Yep. The letter of approval will have a start and end date included within it. So provider and member will be aware of the term of their disenrollment.
And then we have some good visions for how we might be able to inform clients or providers in advance in the future. I think I'm going to just summarize the things that we've gotten in here and make sure that all of our presenters have that after the fact. So thank you so much. I do want to make sure we transition over to the prior authorization portion of this presentation before we run out of time. So if anyone wants to put in more questions, comments, anything they want us to capture either today or in the future, please feel free to do that. And how do our presenters feel about moving on to the next section of the presentation?
I am good to go.
All right, thank you so much. Okay, so just as a reminder, we're going to talk about prior authorizations next, and it's in a level of detail that's going to be most helpful for people who are or may be working with prior authorizations in the provider portal directly. So if this doesn't sound like you, you are free to leave, but if it does sound like something you might be interested in, we recommend that you stay. There's a lot of additional really great information.
All right, thanks, Jessica. So we mentioned prior authorizations when we discussed the CCO disenrollments. So let's take a moment to talk more about what a PA is and how a provider navigates this process. There are times when care needs to be authorized before it is given in order to be covered by OHP. If somebody is a CCO member, providers will need to follow that CCO's prior authorization process. So by definition, prior authorization, or PA, means payment authorization for specified medical services or items given by OHA staff or its contracted agencies prior to the provision of service. A physician referral is not a PA. The prior authorization section of the provider web portal gives providers the ability to submit online prior authorization requests for Oregon fee-for-service clients. Web PA also allows providers to search, review, and track the status of their PA request. So this next slide, I just want to reiterate, I think that this slide is really important because you want to be sure that your PA request is going to go through and want to make sure that you counteract any barriers that you might come across. So it's really important to verify the client is eligible on the date of service for the requested services. Again, I want to reiterate, for services covered by the client's managed care plan, request a PA from that plan. You'll want to use the provider web portal's PA search function to see if a PA for the same client, dates of service, units, and services already exist. If it does, do not submit a new PA. And this one is also particularly important. Verify that you are signed on and acting on behalf of the correct provider. It is crucial to make sure that you are logged on under the correct provider number because this is the only provider who will be able to see the PA on the provider web portal. So when you submit a PA request, you must complete and submit PA requests to save the data entered. Partially completed PA request data cannot be saved. And also too, the session will end after 20 minutes of inactivity. So any work changes that have not been submitted will be lost. So this next slide is just kind of a screenshot of what the PA request looks like in the MMIS web portal. And it's done basically in a few steps. So you'll enter the base information and select in step 1. So you'll select new from the prior authorization menu. The following screen will appear. The screen 1 of 3 allows you to enter PA base information. It is the first screen of the PA request process. It's really important that when you navigate in the provider web portal that you use your tab key and not the enter key. If you use the enter key, it tends to submit it prematurely. So do put in the client ID, the PA assignment, the referring provider ID, and next to the referring provider ID, there is a little search button. So if you are unclear of the providers that you're looking for, their NPI, you can click on that search button, and the search button will actually bring up, and once you type in the provider's name, will bring up any providers that are contracted with the OHA with that name. So I think we can move on to the next slide. So step 2, this screen allows you to enter multiple line items. These are the lines of service that you're wanting to add. You must add a service type code to indicate the type of code, such as procedure code, revenue code, or NDC, National Drug Code, you are requesting the PA for. If you are requesting more than one specific code, then enter a line item for each code. Enter information for the first line item to the screen, and then to add more lines, click on the Add button in the lower right. And then step 3 is you can enter PA notes on the notes screen. This screen allows you to add notes for consideration when reviewing your PA request. You can add a line for each note, and each note can contain up to 4,000 characters. So for the prior authorization process and more information and step-by-step instructions on how to submit a PA, we do have a PA provider handbook online, and this is the link to that provider handbook. So I realize we're going through this rather quickly, so do refer back to this link. It's kind of nice. It'll show you screenshots on how to submit that prior authorization. And with that, I'll hand it back over to Brendan.
Thank you, Arwen. Thank you all. The next slide is going to start discussing the life of a prior authorization or PA request, some of the submission options and how it's set up and reviewed by the RNs. OHA accepts PA submissions through the web-based provider web portal in MMIS, our information system, or via fax, the traditional method. We do not, however, accept prior authorization requests over the phone. Submitting PA requests using MMIS web portal is preferred for the reasons mentioned earlier. It's beneficial because it provides an opportunity for providers to view the determinations online in real time instead of waiting for the snail mail. It also provides you an opportunity to be more responsive if there are shortcomings in the PA, or if there are obstacles that we're trying to work through in the review process. If we're not able to find the right information, if there was an issue with the fax system, for instance, or your attachments, then we can make notes on the PA within the portal that are viewable by the provider, and you can provide, you can respond to it more quickly. Both routes of PA submission, fax and MMIS, require the use of the EDMS cover sheet, as it provides invaluable contact and PA information when completed. One of the most, and I really want to emphasize this, one of the most valuable pieces of information is actually the contact information that is requested on the EDMS cover sheet. That contact information is critical whenever there are issues that can quickly be resolved by a phone call or with a phone call from the clinical unit to the provider's office submitting the request. But without that contact information, it can be very, very difficult, especially if you're a provider that works within a complex network and has a complicated phone service tree. You can imagine, because it happens. So without that contact information, things can get very, very difficult. Super important tidbit of information to remember and relay to your support staff if possible. PA submitted via fax will not be accepted and processed without the EDMS cover sheet, as it is an essential requirement for those submissions. we strongly encourage, ask, request that the EDMS cover sheet be placed on top of the submission packet of supporting documentation, above the actual PA request form. If you have a system that also automatically inserts an agency fax transmittal sheet, cover sheet above it, we are prepared to manage those through the fax system and have it reorganized where the EDMS cover sheet is then placed on top of your cover sheet before the supporting documentation is attached to the PA. So hopefully that's not an issue, but what we ask is that you definitely do what you can do to place that first on top of the submission so it's not lost. I mean, easily referenceable, because it is so important that it is there. Please complete the EDMS cover sheet and include all an office contact, like I mentioned, with a direct phone number. Please don't, unless it's unavoidable, please don't provide us with a call tree, a hotline number that would put us in a loop. The more direct contact we can get, the more interactive we can become and maintain a relationship with a provider making submitting the request and provide response more quickly. Next slide, please. Or no, not next slide. I'm sorry. After the PAs are submitted, the PARs initially review them to make sure that they are technically sound and appropriate. They confirm that PA is needed. If it's not required, they are able to set as informational into an informational status, and a notice will be mailed to the submitting provider and to explain why that a PA is not required for their request. In order to avoid submitting a PA for something that does not require a PA, we really recommend that the provider's offices call the code pairing hotlines to ensure that their specific codes and their requests are being researched for PA requirement. As I mentioned earlier, the PA hotline is more of a overview service that can tell you the status of a PA, but to really get accurate information about the necessity of a PA requires code pairing research, and that is done through the code pairing hotline. It can also be obtained through the MMIS in the web portal to see if the codes pair and if a PA is required, if you have anybody in your staff that is technically savvy enough to take on that role. It goes without mentioning that submitting a PA when a PA is not required, is taxing for all involved, especially the provider's offices, and has the potential to create delays in service or care. So knowing when a PA is required and not required is really fundamental. After the PAs are set up by the PAR team, the RN medical review coordinators review the attached clinical documentation, and they reference established criteria found in the Oregon prioritized list, Oregon administrative rules, AIMS guides, other professional organization guidance to make their determinations of whether or not that request meets criteria for approval. And I want to be perfectly clear and really emphasize that my team's goal is to find a way to approve a PA. We approach PAs to ascertain if it meets approval criteria, not that it falls short and that we should deny it. We work hard to approve requests, and we work hard to provide information to providers and members when appropriate of where a PA falls short and what it would need to be approvable. With that comes a little bit of technical savvy on the provider and the member's side from time to time to understand some of the rules and the nuances, but we do our very best to provide that level of support and understanding. If there are prior authorization requests that the determination is questionable or not clear, complex, RNs can take the request to our medical management committee, or MMC, or MMR, acronym for medical management review. The medical management committee meets weekly, sometimes bi-weekly, depending on staff availability, which has only been an issue as of since March of last year due to the COVID emergency. Our providers are stretched thin with COVID emergency response tasks. So, but we do our very best to meet weekly. And the committee consists of medical doctors, RNs, policy analysts, and subject matter experts who may be involved with the cases that are being reviewed on that particular committee meeting. Once the PA determination is made by the nurse or MMC, the notification letters of determination are sent to the provider and the member. And again, we do our best to provide adequate support and documentation and clarity as to why determinations are made, both approved and denied. For urgent and immediate PAs that are submitted via the fax, we attempt to call the provider's office to notify them of the determination because we acknowledge the urgency of the matter, and we acknowledge that our formal process of postal service mail notification does not rise to the level of adequate notification on an immediate or even urgent request. So I hope that is what you are all seeing on the receiving end, and that it's adequate. Now I'll go to the next slide. Criteria used to make determinations, and I kind of just touched on this a little bit. The criteria that we use to make our determinations are primarily the prioritized list of health services, the Oregon Administrative Rules, AIMS criteria, and other evidence-based clinical criteria. And this slide offers some links to where those resources are available. The last bullet point lists ACOG as being one of our resources for making clinical determinations for out-of-hospital birth-related requests. Next slide. When you don't agree with a determination. As a provider, if you don't agree with a determination, the provider clinical support unit offers the opportunity for the provider to request appeal through our medical management committee and a medical management review. That is something that I feel very strongly is important because it allows for the provider to express any concerns that kind of fall outside of the standard black and white determinations, and includes a lot of gray factors that need to be discussed in more depth. And to initiate an appeal from a provider level, it requires you to contact the PA hotline, the provider clinical support unit hotline, and that's going to be option 3 from the main hotline number. And they will give you instructions on how to initiate it, and it will require the inclusion of a letter of medical necessity attached to the prior authorization to better explain from a provider perspective why this unique request should be approved, and to offer you an opportunity to better explain the circumstances of this request. Aside from the provider appeal option, members always maintain hearing rights for any denial. So letters of denial that are issued to the provider and the member, the version that the member receives always should receive instructions for hearing rights in each of those letters. And it comes in multiple languages and provides instructions of how they can reach out to the hearings team in OHA to initiate a hearing request through the Office of Administrative Hearings. Touching again on the communication with the provider clinical support unit, here is another slide that lists our hotline numbers. It is the same base line with 2 different options. In fact, this baseline will get you and your staff to client services and the provider services unit, and I believe claims and encounters as well, based on which options you select. But for the PA hotline, which is the the basic overview hotline for PA status, it's option 3. For the code pairing hotline, for more detailed analysis of your request based on the codes and whether or not a PA is required for that specific request, it's going to be option 4. Questions about specific PAs, maybe both the PARs and the RNs answering those phone calls depending on which option you select. External letters or hard copies are mailed to the members and submitting providers. Submitting providers are also able to view external letters containing the PA determination in real time in MMAS if they utilize the web portal. So that's noteworthy as well. Not only are there notes that are viewable by the providers utilizing the web portal, but the letters that are generated are also attached to the prior authorization request as well. So you'd be able to see that letter that will get to you via mail. You'll be able to see the identical letter days earlier once the determination is made. And those are generated the night after the outcome, the determination of the prior authorization. So there is a business cycle that generates the letter between the end of one business day and the beginning of the next. So if it's determined on Wednesday, then that letter will be viewable on Thursday. Common PCSU questions and answers. What if OHP is secondary coverage? The same PA process needs to be followed even if OHP is secondary. If services require a PA, the claim won't pay without the approved PA in place. So it is essential that it be submitted and approved. Members can't be balance billed for covered services or treatments that have been denied due to provider error. And this is in rule. The example of provider errors: required documentation that isn't submitted, prior authorization not obtained when necessary. Again, the members cannot be balance billed for these services when the claim is denied due to provider error. When members have other coverage like TPL, third-party liability, providers must make reasonable efforts to obtain payment first from all other resources. Medicaid is considered to always be the payer of last resort. How are retros handled? Retroactive disenrollments. The rules for retro eligibility are outlined in OAR, and it's listed here in the slide. OAR 410, 120, 1320, Section 5, small a, small b. Providers are responsible to verify member eligibility at the time of service, at the time when services are provided, which includes verification of client benefit package to cover the services that are rendered. And per General Rule 410, 120, 1140, Sections 1, small a, small b, and Sections 2, when the RNs review for retroactive PA requests, if OHA eligibility was available in MMIS at the time of services, it will most likely be denied for not meeting retro eligibility requirements. So it's really, really important that you check OHP eligibility in MMS or by calling the hotlines every time to be safe, to ensure that eligibility is not an issue. What if something is needed emergently? Let's see. Best way to put it, medical care that is required emergently does not require a prior authorization, I think is the best way to put that. True emergent medical interventions do not require PA, and the claims need to be billed as emergent on your end from the provider's office to ensure that they're being processed properly, because services can be billed as either or emergent or urgent routine. So it's important that if it's an emergency service that it's billed as such. If it's not billed as an emergency and it was submitted as a routine, it may be denied because it doesn't meet criteria. So make sure that they're being categorized appropriately when the claim is being submitted. Another common question is, what is code pairing? Code pairing is a process of determining OHP coverage or funding for a specific condition or diagnosis, and if it pairs or is eligible for reimbursement with a specific procedure based on the CPT or HCPCS codes, HCPCS codes. So pairing the diagnosis and procedure codes tells us if a PA is required, if the request is funded. Absolutely essential part of this process, of all of our process, because it makes sure that the appropriate codes are being utilized and honored. Excuse me, sorry about that phone call. And it got me mentally off track a little bit. Using the correct codes, really, really important to make sure that you have appropriate support staff that is versed at coding, because it can really alleviate a lot of delays and obstacles and, missed denials of claims, missed denials of authorization information. So using the correct codes. An example of code pairing is a diagnosis code S43.431A. It's a labrum lesion over the right shoulder, in CPT 29807, shoulder arthroscopy or in surgery. This information the information provided by the RN would be, these codes pair above the funding line on 418, and code 29807 does not require a PA. So that is a typical response that you would expect to get when provided with the accurate codes when they fall above the funding line and are reimbursable and covered benefits. What is the average turnaround for PA processing? I'm really, really happy to report that over the past 2 years, the processing time for PAs, and I say PAs excluding CCO disenrollment fee-for-service PAs, because those take a little more time given the complexities of them in the collaboration that is required between provider and CCO. But for regular service PAs, our unit expectation is around 10 days. And for the past couple of years, barring or with the exception of a couple spikes with COVID, staff shortages and things like that were unpredictable, we have been maintaining a turnaround of 7 calendar days or less for almost 2 years now. So I think that is a phenomenal achievement, and I hope that you as providers are seeing that kind of turnaround on your ends, and we appreciate the role that the provider population plays in that success, because the higher the quality of submissions that we receive, the better we can do at processing them and issuing determinations in a quick turnaround manner. So the more we can do to help each other, the better we can all do, and the better that our members can be served by all of us, and the patients can get the services that they need in a timely manner. For urgent PAs, the expectation is that we have a turnaround or determination issued in 72 hours, business hours. And for immediate status PAs, the expectation is that we issue a determination within 24 business hours. So that's something to also keep in mind. 24 hours for immediate, 72 for urgent and routine. Please know that if the PA is reviewable, meaning complete and appropriate, you're going to have that back inside of a week. So we were pretty determined to keep that expectation consistent. Appropriate prior authorization prioritization is really essential to help ensure that our process continues to go smoothly. So being honest about the priority of a PA, knowing that a routine PA can be processed in 7 days, there's no incentive to mistakenly label the prioritization as an immediate or urgent if you know that it's routine, when you're going to get it back within 7 days, because that requires us to conduct an initial review and then rule out as immediate or urgent and place it back in the queue. So it does cause unfortunate delays and actually slows down the overall process. So we ask for your assistance with that. What kinds of PAs does the PCSU most commonly review? Most common, imaging, surgeries, durable medical equipment is a huge volume PA for us. We do some out-of-hospital births. Therapies are also very prevalent. Home health, transplants, and also the fee-for-service, which, like I said, they're not a high volume PA, but they are Probably tied with out-of-hospital birth requests in terms of complexity and involvement with the team. So the next slide is some additional PA resources. Instructions for submitting prior authorization requests for Oregon Medicaid providers. For those who'd like details, instructions about how to submit a PA via the MMIS web portal or fax, you can use this link. There's a 23-page document that walks you through the PA process. That's pretty helpful. If you're a provider and don't yet have access to the portal, please contact Arwen's team at the Provider Services Unit to get set up for that. And their phone number is the same base hotline phone number at 800-336-6016, and they're going to be option 5. They are extremely well versed at providing provider support and education on how to use the web portal. And I strongly encourage you all, if you don't already, to start exploring your options and utilizing that. And I think you will find it to be much more user-friendly and beneficial for your processes as well as ours in providing care for the members through these requests. If you have any questions that weren't addressed thus far, I'm trying to right now look back at the chat. I don't, correct me if I'm wrong, I don't see any new questions since our earlier break. If you have any additional questions, we really welcome them. So you can reach us at, again, the base number 800-336-6016, option 3 to speak to a PAR, or option 4 to speak to an RN clinical reviewer and the provider clinical support unit. The hotline operates 8 to 5, like I said earlier today, except for if you experience a message that it's out of service, we're probably in a meeting and we'll be returning within an hour usually. So, and those are limited. Those don't happen that frequently, once, twice a week at the most. We're also closed major holidays, and it's not a 24-hour hotline. It also does not allow for a voicemail, so it does unfortunately require you to call back.
Thank you so
Other
much.
than that, other than that, I just wanted to say thanks to everybody for being here. I really appreciate the opportunity to talk to you and offer our support to you to help our members as much as possible at any turns. Don't hesitate to reach out to us. Thank you for your time.
And thank you, Brendan. Gosh, that was a ton of information in a couple slides. That was a little bit of a mini marathon there. I think I see 2 questions that we might want to address. And if people have more, please feel free to key them into the question box. It's a question about if mental health prior authorizations work the same way, or if there's anything we should know about mental health specific authorizations.
Very good question. Great question. Thank you, Jennifer. And no, the answer is simply is no. The only mental health prior authorizations that my group would manage would be those mental health disenrollment requests from the CCO Disenrollment, continuity of care, open card. That is the only mental health prior authorization request that my team manages. So all other requirements or support questions would follow a completely different pathway. Then that's a whole nother conversation that the OHA can have in and of itself. But thank you for calling that very, very important aspect out. But it is not the same process.
Thank you. And then a question about how to best handle retro enrollment if a patient did not have OHP when the services were rendered and then later receives that retro coverage.
It's going to be rule based. So if the services and the timelines are approvable, that service can be submitted for PA retro approval for the services, given that the coverage was retro approved, if I'm understanding that correctly. But it has to meet the criteria that's outlined in rule. So I guess that's my way of saying yes and no. There are some that aren't going to be approvable because of the circumstances of the request, maybe because of a timeliness issue or something. There's lots of variables there, but we can definitely help out. If ever in doubt, please give us a call and we can look at the specific details of these requests.
That's very helpful. Thank you. I think those were the only unanswered questions that we have, and we're just about to hit 10 a.m., so I think we are remarkably on track, thanks to our excellent presenters today. I'll bring us to our last slide. Just to close it out, I want to thank Arwen and Brendan for giving us really in-depth and excellent information today on the topics at hand. I want to thank everyone who was engaged, those of you who asked questions or maybe are just still in the same phase I'm at, where every time I continue to look at the slide deck, I learn more about these processes and new questions will arise. This is not the end of this conversation, this is the beginning. So I think Brendan gave some great like phone numbers to get more information or to talk specifics. I want to continue to offer my services as the provider coordinator, especially if there's any questions people have specific to the community partner role, or your provider versus community partner hat that you may be wearing. And we look forward to continuing to have more sessions like this. So if there are other topics that you want to learn more about, if there are other people you want to meet internal to OHA, then I would love to help facilitate making sure that our collaborative webinars continue to be as useful as possible for you all. With that said, and I'm sorry for the sound issues. I think the crackling has come and gone. It doesn't seem to be tied to any one person anymore, but we persevered, and hopefully the sound quality was good enough that you were able to hear our good content today. With that said, I think I'm going to close us out. Thank you all so much. This webinar was recorded, and so it will be up in about a week in GroupSite. And I did see a few requests to make sure that this information gets to you all right away. So look today or tomorrow for an email with our slide deck so you have that while we get the other portions of this processed. And thank you so much. Have a great day, everyone.